welcome to the show. I'm excited to be back. This is the Healthcare Inspired Podcast, and I'm here with my special guest, Dr. CJ Wolf, and Maya Turner. Hello, everyone.
Hello.
Oh, this is going to be a good show. I'm
It
excited.
is. It's going to be a great show. The one and only.
The one and only CJ Wolf, and I
Wait,
hope
Karen.
when I'm in Vegas this year in a couple months, I get to meet you in the flesh. I'm looking forward to
Right.
actually we get so busy at HealthCon and we kind of pass each other, I think, in the shuffle, and it's going to be nice. So CJ, tell us, what are you speaking on at HealthCon in Vegas this year?
HealthCon, I'm speaking on these new E&M guidelines that aren't really new anymore, right? But they are new to a lot of people. I do a lot of monitoring of cases, settlements and those sorts of things. And, a lot of those cases and settlements lag like by 4 or 5 years. So any E&M cases that we still see are mostly the old guidelines. Well, I found a case that it was a settlement based off of the new E&M guidelines.
What?
And so that was the first one that I had seen. And so that's what I'm talking about, is I'm going to dissect that a little bit and try to read the tea leaves as to, okay, we've seen all these settlements for years and years on the old E&M guidelines, but here's one. It's one of the first ones. I think it's the first one I've ever seen on the new E&M guidelines. So anyway, that's kind of what I'm talking about.
Interesting.
Exciting.
Yeah.
And Maya, what are you speaking on?
I'm speaking on observation and condition code 44 that really kind of talks about the documentation pitfalls and the dotted lines that are related to gaps in clinical communication that doctors fail to read and or capture in the note, because it has an effect on the escalation of care. And so we're going to be talking about that in the facility setting. And I think because there's not a lot of communication between clinical staff and physicians, that it becomes a problem when stuff isn't captured in the documentation. And this is not just physicians, it's really just across the board, because the medical record should be a method of communication. And it's not always read when the communication is written. And so I want to talk about that, because that's something that we are not exploring. And that's a lot of, and it's because of education, really, because everybody thinks it's just and nobody's thinking that everybody has to follow their work, so it's important. And I think we need to shed some light on it from an outpatient a CDI perspective, as well as the inpatient perspective, because it really kind of bridges the gap.
I agree. And, I think about, I definitely agree. I think about the episode today that we're here to talk about is the physician thought process. We want our audience to really think about what physicians go through. I'm a huge patient advocate and physician advocate. The two things that have to meet for proper healthcare is the physician to tell us what their thought process is. And then also we want to see the patient's interaction with the physician in that documentation. It doesn't always happen. We see some disconnects. So one of the things that we talked about previously, Maya, was that we see have those phantom diagnoses that often make their way into the chart, where like the HPI is like all this stuff's going on. The patient's having this great story going on. We get down to the exam, it's all normal. And then they end up with a hepatic encephalopathy. And wonder, where did this come from? Like, I'm missing a piece here. I'll ask you, Dr. Wolf, just briefly explain to us, from a physician's standpoint, how do you view documentation, not only from a clinical point of view, but what's your view of it and its use in healthcare?
Yeah, I mean, it really is. It's the foundation of care, right? Mm-hmm. Because care is often not done in a silo, right? So you have a doctor or a clinician, a nurse practitioner, whoever it is treating a patient. There was treatment before, and there's going to be treatment after, and there's going to be others interacting with that patient. And so it's that documentation tells your part of the story in the greater story of this patient, right? The real story is the patient. Their story is what they're dealing with from birth to death, we have a small little role to play. And depending on your specialty, it might be, much more involved depending on what is going on with that patient. So it really lays the foundation for all the clinical care. So even before we get to coding, it's the way that you communicate your thought process. It's the way you communicate what you think the condition might be. Sometimes, you don't get a diagnosis in that first visit, right? These are a lot of conditions and diseases are things that take weeks, months, even years to fully understand and diagnose. Others are simpler and you diagnose it right away. So it's kind of getting that full picture. And then a patient you may be seeing a patient for 20 years, they've got this history, and now they come in with a brand new problem. And so it's trying to put all of that together. The other thing I like to say is that in healthcare, in medicine at least, medical decisions are made based off of population studies. So when I'm treating somebody with hypertension, there's been multiple medical studies with patients with hypertension, and let's say 92% responded this way. Well, I have to take that population study and now apply it just to Maya or just to Jennifer or just to one person. And that one person may not fit the mold of that study. And so that's really the trick in medicine, in my opinion, is it's taking clinical studies of populations and now saying, okay, what decisions do I make for an individual?
There it is right there. Individual. I know I'm going to quote our good friend Christine Hall. What did you see today? I think, if you guys were, you guys weren't in Charleston with us, but in Charleston, Christine had a sweater on that said today on it. And it was just a perfect representation of our presentation on revenue cycle. But it's really what we think about is we want to know what you did today. And that is, of course, in the professional fee side of medicine, which we're here to talk about today, is how E&M comes into play for those physicians that are seeing patients on an individual data service, on a face-to-face encounter. What is happening at that face-to-face encounter that we can get reimbursed for. And that's the key. We're trying to help physicians, understand is that we know you're doing a lot of stuff for this patient, but not everything you're doing, unfortunately, is reimbursable. We would love to give you credit for every little piece that you touch and things you talk about. And a lot of it is reimbursable. We just have to get a clear picture of what is really taking place to give you all of those little nuances captured in your documentation into an actual code or multiple codes in some cases. We want to make sure we get that. So we're going to kind of break down just for a second, just the E&M service itself. It is evaluation and management. It is the first thing that happens to you before any services are done. You have to meet with your physician, whether it's your primary care physician or a specialist, and they need to examine you. They need to get a history, right? They need to conduct an examination. They're going to look at records, previous records. And then after all that testing, they review or even order themselves. They're going to say, okay, at the end of the day, after everything being reviewed today, this is what I feel is the case and what we should do about it.
That's right.
Now, Dr. Wolf, how would you explain the encounter and what does a physician think about from the beginning to the end? What is going through your head when you process history to MDM?
Yeah, it's a mystery, right? You're trying to solve a mystery. No patient comes in with a nice sign around their neck saying, I have a third degree right bundle branch block, so please treat me, right? You have to take signs and symptoms. And unfortunately, these diseases and conditions don't follow all the same rules. So, the typical patient, let's take a diabetic patient that has polydipsia, polyuria, polyphagia. That's kind of the textbook presentation of a diabetic patient. But that doesn't mean they have to follow those rules, right? The disease doesn't know that they're textbook or not textbook. So what clinicians are always doing is thinking, am I on the right track? Is there something abnormal here? Is there an atypical presentation for this? So for example, with chest pain, men present with heart attacks a little bit different than women, quite a bit different. And so the same symptoms might not be there, but it can be still as deadly and risky. And so, and unfortunately, a lot in medicine has focused on how white men present. A lot of clinical trials have been done that way. I know in research, there's huge efforts to involve other populations because obviously it's a diverse population and you need to treat people according to what their unique circumstances are. But what doctors are really doing is they're walking through in their mind, okay, what do I think this is? What little pieces of evidence are adding to support my hypothesis? What are taking away from it? And then, and to the point of what kind of how you started off with, it's like, how do you get all that stuff that they're doing in their head down on paper or nowadays electronic medical record so that that thought process is a little bit more clear so that coders or even the doctor, whoever's picking the code, can choose the right E&M code.
Exactly. And so I'm just going to ask you, Maya, from an auditor's perspective and someone that's been in healthcare a long time on the business side, you've seen a lot of things go right and a lot of things go wrong. So when you talk to a physician, right, you're laughing, I know. When you talk to a physician, what are some of the things that you kind of need to get straight when you get to know a new physician you're auditing for or that you're coding for so that you can kind of make sure you're both on the same page?
I always, when I'm educating physicians, I always say that the auditors are the cool cousins with the beer at the party, right? And and we're the cool cousins, but because we know you. But you have to write the documentation like nobody knows you, and that somebody's coming in who doesn't know who you are or who that patient is, and they can get an entire picture of what's happening. Because a lot of times it's inferred that someone understands what those initials mean or what those test results mean. And because auditors or RAC audits are not clinically driven, they're monetarily driven, right? And because they're monetarily driven and they're not clinically trained, they just want to know what's obvious and what makes sense and what doesn't. So you have to make it so that whoever is reading the note understands what's happening, knows that they have no bias between what the physician is writing and what the patient, where the patient is presenting, and that it's a streamline and that nobody can question the integrity of the record because everything is there.
I 100% agree. I'll give you a couple of examples. So I work in ENT a lot. And so when I'm reviewing these particular operative reports, whether it's a tonsillectomy, adenoidectomy, or a myringotomy with tubes. So what I'm looking at is, did you give me enough to justify that you did this procedure? Mm-hmm. And sometimes what I'm seeing is they tell me the findings. They found that they sent these off to the lab, right? But they don't tell me how they did it. So they're expecting me to actually bill these as performed when I don't have evidence that you actually approached the patient. All I see is that you found them and you're sending them off. Like at some point, yes, you did take them out potentially, but I don't see evidence of it. Like you didn't actually say that you approached the patient, how you did it, what instrumentation you used. And there's a lot of compliance issues with that. And then we go into maybe a myringotomy tube. Sometimes with those tubes, they actually go in through an old site and they actually will remove the tube through an old site or put it back in, right? But they don't tell me what they did around that site to get credit for that procedure code. So those are a couple examples that in ENT that we have. And there's others in various specialties. Now, Dr. Wolf is going to be speaking at our upcoming dermatology virtual conference next month on March 14th and 15th. And so you're going to be talking about the MDM portion of our documentation, which is what we use now for E&M. And so I would like you just to tell our audience a little bit about, as a physician, just let's take dermatology, for instance. What are some of the things that physicians are missing that are affecting that capture of the right level?
Yeah, I think they, and again, we're painting with broad strokes here. Of course, there are some physicians who do an excellent job, and there are some who do extremely poor job, and then there's a bunch in the middle. So the comments that I'm going to provide I'm couching it with the disclaimer that, yeah, it's going to depend on the physician, and not everyone does this. But in general, what I observe is that they often fail to put their thinking down to kind of demonstrate the severity of the condition. So they know that it's maybe severe or high risk. And as you mentioned, Jennifer, the E&M codes now, you either pick off of time or off of medical decision making. And so getting the severity of that medical decision making down on paper is so essential. Otherwise, it's going to be a lower level. And most of the time, they're doing a lot of this work. So, for example, in derm, so let's say somebody has a lesion. If they just call it a lesion, and they, let's use this a pearly plaque. So the physician sees a pearly plaque. Well, that's almost code language in doctor speak for dermatologists, as I'm thinking that's a basal cell carcinoma. Because pearly plaque-ish types of lesions, that's the textbook lesion for a basal cell carcinoma. But what if somebody who's reading this note, to your point, maybe an auditor or something is reading this note and they don't know that?
Right.
Well, another doctor reads it and they're thinking, well, doc, did you do a biopsy to rule out this carcinoma? So I think part of it is making sure the doctors understand that what you just did in your brain, if you can get that out on paper, that's going to help auditors and show that, oh, this could be a basal cell carcinoma. And now I see that this could be a higher risk type of condition than when it's just, I noticed a pearly plaque lesion. Now, to be fair, also now, if I play the other side, on the doctor's side, I hear doctors say all the time, well, why do I have to explain that? Can't I argue that if I get this denied? Yeah. Yes, you can. And I have done arguments for clients when they get denied. But wouldn't you rather avoid that? So I'm not saying you're going to get thrown in jail for not saying it's basal cell, right? But wouldn't you rather just avoid that whole mess and the whole argument by being clear up front and saying, look, I see this pearly plaque, on the forehead of the patient. My suspicion is this is a basal cell carcinoma. In order to rule that out, I'm doing X, Y, and Z. That's a whole lot easier than hiring me as a consultant to come in and argue with, on appeal with the administrative law judge. Why do you want to go through that headache? I might win, and I've done that for clients before, but you've just spent a lot of money and a lot of time and frustration to get that win. So yes, fine, you didn't have to say the words I told you, but wouldn't it have been better to avoid that in the first place by being as clear as possible up front?
100% agree. And, both Maya and I at times have worked in that space where we're helping explain what the documentation is saying, because there is a potential legal issue. There was an issue where I was sent some records and the patient was wanting to sue the clinic for misrepresentation of their medical records. And so I was brought in just to review one chart. That's all I was asked to do, and just give my professional opinion based on the guidelines and what I reviewed. And there was something to say about the patient's point of view. And so I'm a patient advocate. Like I said, I'm all about the patients. I'm a patient at times. My family, of course, I think about them, and they really truly don't understand where a physician gets from what they actually talk to you about, what they document, and then gets a bill, and they get a bill for. So I like to calm it down, and I try to explain it in a very easy to understand for the patient. I don't use the jargon that we use in healthcare because they don't understand it. So I like to say, the physician spends a lot of time, I will let you know, outside of the room where they're not in front of you. And they spend time in front of you as well. So there's different ways that they can capture what they learn about your condition and still get credit for that and get to bill you for the time that they're spending, not just in the room with you, but also doing activities that help them identify what they should do next. And so I try to kind of make it easy to understand that I guarantee you they did this work because I see the documentation. I have evidence. I have labs, I have x-rays, I have evidence that they actually did stuff for you to come to this conclusion. And at the end of the day, it is their professional opinion on the risk and the identification of what's wrong with you and how that complements the risk that makes it a level 4 or 5.
And if I could just to that point, if you read the new E&M guidelines, it talks about how physicians can use the common language for risk. Let
Yeah,
me just
yeah,
find
yeah.
this real quick for you.
Yep.
Yeah, I know exactly what you're talking about. Yep.
Right? Like they don't have to rely on some medical.
Yeah.
Yeah. So I think you
Are
probably
you
already.
referring to the clinical intuitiveness that's related to risk?
Yeah, where it
Yeah.
says, sorry, let me.
No, go right
The
ahead.
term risk. Yeah, go ahead.
What I was going to say, one of the things I had to have a conversation with someone recently. I was doing education for a physician and then a medical practice when it was a physician education for ENT. And I wanted to let them know, we 100% want you to get credit for the things that you're doing. And another thing I pointed out was just so you know, the patient doesn't have to go forward with a surgery for you to get credit for recommending it.
Yes.
One thing they always forget, and they think if they don't do it, I don't get to count this surgical,
Yeah.
whether it's, it's
Right.
It's the same for drug management too.
Yeah.
You have to refill a prescription in order to get credit for drug management.
Yeah. So
Yeah.
it's going to be an elective or a non-elective surgery,
Right.
if they give us the risk that patient, and I always say, the risk is different for every person. It's risky for any surgery, right? But like I use the example of my ankle because I'm in ortho a lot. So I broke my ankle 3 years ago, and so I'm relatively healthy. I was in my late 30s when it happened, and so I didn't have any comorbidities really. I was pretty healthy, so my risk to having that procedure wasn't real bad. But if another patient has a lot of risk, like they smoke or they have all these comorbidities, they're going to have to consider, is surgery safe for them? Now, an ankle surgery may not be as risky to some people that as like a hip replacement, but it's still a risk because of opening them up exposes them to many elements. And so, Dr. Wolf, let me use as an example. If you're going to compare a patient with diabetes, hypertension, CKD, and they're a smoker, they have, of course, maybe CHF too, and someone like myself who has no other conditions other than this, what's the difference? What are you considering?
Yeah, so you are considering all of the contingencies, right? So the language that I was looking for, I found it says trained clinicians apply common language usage meaning to terms such as high, medium, low, or minimal risk, and do not require quantification of these definitions, though quantification can be used, may be provided when evidence-based medicine has established probabilities. So what you just described are these probabilities. Everything in medicine is probabilities. And so those are population probabilities. And now you have to apply it to this one patient. Wow. So as you just described, somebody who has diabetes, if they have peripheral neuropathy and poor circulation, they heal more poorly. So if you're doing ankle surgery on a diabetic, the complications could be more severe. It doesn't mean it's automatic, but to your point, if you're a smoker, if you're doing all these other things, the trick is I think physicians need to be coached in a good way. I'm not saying in an inappropriate way, to say, doctor, all that stuff you just told me, let's get it out there in the documentation. Let's document that this patient had these 6 comorbidities. That's why the surgery is a little more risky for them, as opposed to this healthy 21-year-old, male who has no other conditions whatsoever. He'll probably be out running and partying by Friday night. Whereas this other patient, it might take 2 weeks to recover.
Right. It's true, right? And another thing that I think of, I did a couple audits previously for some oncology facilities or practitioners, and one of the things I noticed even there, I think a lot of times because it's cancer, you automatically go level 5, level 5, level 5, and I have to kind of point out to them it's not always level 5 because it has to do with what you're doing today. So
that's right.
They could have cancer, that you're treating, and they're actually coming along quite nicely, and they're responding to treatment. And there really may be more 4 in some cases, depending on what you're doing for them.
Or even less. So years ago, I was the director of billing compliance at MD Anderson Cancer Center, a large, well-known cancer center in Houston, Texas area. And we had this conversation a gazillion times with our doctors. It's like, yeah, I know they have cancer, but you just said they're doing absolutely great and there's nothing wrong. And
responding well to meds.
yeah, your point is well taken. Just because somebody has cancer, that doesn't mean that today they are going to die. Just like somebody with HIV, you know, 3 years from now, they might get AIDS. They might progress to AIDS. But there's so many good medications now that people can live with HIV for decades.
Yeah.
And they're completely fine. So yes, you have HIV, but that doesn't mean today's visit means you're going to die. And quite the contrary, right? And so that's an excellent point you make. You got to think about, and you mentioned it earlier with Christine's shirt that said today. That's the spot. That's spot on. We have to be thinking about what is presenting today. Let's paint the picture today accurately.
Yeah. I've had that kind of conversation too with a pulmonologist. He has COPD. He's going to die. You're like, wait, but are they going to die today? Did they walk out of the office? Did they pass out when they came to the room? Well, no, but what's happening today? And so it kind of closed down the argument. He wound up retiring anyway. So
sometimes that's the easier way to go.
Oh my goodness. I'm telling you what, those pulmonary docs, you know, they always want to, I love them to death, but because of the fact that they're doing so much, and sometimes they are truly dealing with a critical care situation.
Yeah.
And there's a difference between what a physician's thought process is in critical care and what is reimbursable. And because again, you need a consultant on your side. And I always tell practices, I'm not trying to just draft some more money from your bank account. I'm just trying to help you see the benefit of having me on retainer, because what if tomorrow you have this huge issue and you realize, oh no, we didn't do this. And
what do we do?
I know, previously Sean Weiss on their podcast, they have every Monday morning, the discussion was mentioning about the fact that if it exists somewhere, if there is documented evidence of a policy somewhere, and you can't say, I didn't know, because you should have known because it existed.
Yeah, exactly. You know, and you know, we were talking about dermatology, and there was a case a few months ago, maybe it's now 6 or 7 months ago, where a physician, this was in Chicago, was had a settlement because they were overdoing the excision of lesions.
I think
and it wasn't medically necessary. Do you remember that case where it wasn't medically necessary? The doctor's practice specialized in kind of cancer prevention and cancer care, but that doesn't mean that every time a patient comes in with a skin lesion, it needs to be removed. And what was alleged in this particular case is that the doctor was removing skin lesions more frequently than they needed to be removed. I don't know if you can see on the camera, I have this mole that's been on my neck right there for a long time. That mole has not changed in 30 years. Right. And so I keep a good eye on it, but just because I go into a doctor and he has a scalpel doesn't mean he should be cutting off 29 moles today. So there's this concept of medical necessity as well that I know from a coding perspective, we don't always delve into, because you know, a lot of coders, and rightfully so, they're not necessarily trained to make a judgment call on, was it medically necessary to remove that mole today? But they often are looking at encounters, and they might be the first ones to recognize something seems out of place. I might not be the final decision maker to say that that's wrong, but I might be the first one who's seen the tip of the iceberg, and I can at least speak up and make sure that's done in a compliant way.
Yeah, and I think you know, you were 100% right. I'm glad you mentioned that, because I kind of battle that in my head, because I was a biller before I was a coder, so my brain always goes back there. And so when I'm coding, I'm always thinking defensively of, I'm looking at the LCD policies. I'm looking at LCD policies before I even finalize my code. Now I have to code what is documented. But what I'm also looking for in lesions, because, you know, in ENT, we do a lot of lesions. So, and I'm looking at that. So before I even bill it out, I'm thinking, well, you know what? I see that there might be an issue here because documentation doesn't really support what I know is covered. And I think I'm pretty confident that based on everything else I'm reading, that there is evidence here, but I just need to be a little more clear. So
Right.
before
Right.
I even go down that road, I'm going to go back to my physician and say, can we just have a conversation here? Because I want to let you know this may or may not be covered, but I need to know if this actually occurred, if this is what you're trying to say here.
Right.
Can you be a little more clear for the insurance policy that it tells us what they need documented? Now, I'm not trying to lead them down a road where they're
Right.
trying to document something that's not covered, but I want them to see the connection that I know you did this because I've seen you do it differently before.
Right.
The way you
Right.
worded it last time was very clear. So can
Right.
we try again to do that this time? And that's what it's about, is decreasing that risk. Every time you create a denial opportunity, you're creating more risk for your organization. And when I go into a practice and I see $1.4 million in AR,
Oh,
and I see maybe like 40% of that is over 120 days.
yeah.
In
That's
some
a
cases,
problem.
it's higher. And
Yeah.
that tells me a lot. That
Yeah.
tells me that somebody is not looking at policies
Nope.
and they are not working the AR, obviously, because it got to 120 days. And there's a lot that can tell you that. You can look at whose responsibility, who kind of fell down here. Was it the coder? Was it the physician? Was it the biller?
Right.
Who had their hand in here that kind of led down this way? What do you think, Maya?
I think, and it's interesting because I think that it's all contingent upon culture. Um, what the coder is able to ask the doctor or even approachable to the doctor, because you have that culture where it's like do not touch, or I forget what the Latin term of it, you know what I mean? And so, it's almost funny because it always, like the organization that I work for, everything is in different departments and it goes through different departments, whereas if you're in an office and you have the coder and the biller or whatever who is working, then it's easy for you to have that communication. But when you're dealing with, a larger organization and you deal with compliance and you have education, then it becomes a more formalized process. And then the physician seems to be more defensive in regards to what their documentation is. So it's all, to me, it's just all in a matter of approach and, how you visualize the dollar to the physician, because I don't think they always see the dollar when they're documenting. And because of that, you can't necessarily put that in a box, but you have to practicalize it or make it practical for them to understand it.
Yeah, I mean, let me ask you this, Dr. Wolf. If I came to you as a physician and you knew nothing like you know today, and I said, okay, so you paid me X amount of dollars and I billed this out wrong, and you've already paid my salary and my insurance and all that. I have to do it again. I just cost you $25. It came back 3 times. I just cost you $75 and you're only getting paid 50. So you're kind of in the whole 25. Like, how would you feel?
Yeah, I'm like, thank you for expressing it that way, because I never thought this coding stuff was important before. And now you're putting it into language that I understand, and that makes me stand up and pay attention to what you have to say.
Right.
Rather than coming to me and saying, this is coded wrong. Right? The way you just described it is much more powerful and impactful.
Yeah.
It is. When I tell physicians that, and this is just an on average, MGMA came up with this, others have come up with a similar, equation, that on average, it costs about $25 and now, of course, before inflation hit, to work a claim. When you consider the reworking and waiting 30 days and all of the hour, maybe sometimes it takes a whole hour of time to figure out what's wrong with a claim.
That's right.
It's insane. So
it could be something that's just so simple as a contract. You didn't do this. Oh yeah.
Don't get me started on contracts, girl. We'll be here all day. But that's what I do, is I review contracts. But yeah, it's fun, but it's not something everyone enjoys. But I do enjoy reading some contracts and figuring out that is the piece that's missing. And so I do love that. Now let's go back and talk about those 3 pieces of MDM just for a minute, because that is the bulk of what physicians are looking at usually. And yeah, they can bill by time, but we don't want to abuse that, obviously. So we want to make sure that we're understanding those three components. So the first one, let's talk about, which is the problem addressed. So we have minimal, low, moderate, and high. So for our actual levels. And so we think about, okay, I'm going to start with low because minimal is what it is, but low.
Yeah.
Sometimes there's a huge question of the difference between low and minimal or low and moderate. And so I wanted to kind of get the point across. What are some of the thought processes that you go through as a physician to put those in a bucket? Acute, chronic, exacerbated. What are some of those things you want to consider?
Yeah, so those are great questions. So you have exacerbation, then you have like severe exacerbation, right? And so it's like, how do we know the difference between those two? Well, the first thing I would tell my doctors is you get to decide in some form or fashion what is simple exacerbation or what is severe. So use those words. I'm telling you right now, doctor, as your educator, that this level is, you just say there's side effects or exacerbation, and this next one is it's severe. So use those terms for me. Put those in the medical record. You're the one who gets to tell me if they're severe or not. So I like to see, and as I'm doing audits for clients and those sorts of things, I'd like to bring that back to the doctor and say, look, I'm not you. I'm not the specialist here. You are the licensed specialist. I have a little bit of medical training. But when I read this, I don't want to put words in your mouth, but these types of phrases make me think that this is a severe exacerbation, right? So let's say somebody has some sort of respiratory side effect to a drug that they're taking, and the doctor puts them on an inhaler today and a steroid for the next 10 days. That tells me that whatever side effect they're having is pretty severe.
Yeah.
Because you, in general, again, there can be exceptions, but in general, you're not going to put a patient on steroids for 10 days and an inhaler if that respiratory condition isn't somewhat severe. So they may have never used the word severe. So I go back and I say, again, I'm not putting words in your mouth, but the fact that you put this patient on a bronchodilator and steroids because of the side effect that they're experiencing, that seems pretty severe to me. If you feel like it's severe, doctor, will you say so? And then they can make the decision. No, I don't actually think it's severe. I think it's just a side effect. Okay, I'm not putting words in your mouth. Great. But then now we've just established what level that is versus severe.
Right.
Exactly. And I think sometimes they miss I always let people read the full description of that definition. Because when the exacerbated one, it says side effects of treatment is also one. There's a lot of ors in there. And I like to say ors are in there for a reason, because you can use any one of those will get you to that moderate level there, at least in the problems addressed section. Because remember, it's problems addressed. So you have to address that problem. And so how are you going to address it? Well, you're going to move into that data component potentially, and you're going to take some labs. You're going to talk to the family. You're going to talk to the physician. And that may not happen. That may happen before the visit, during the visit, after the visit. But it's like you're going to either order review or all this stuff's going to happen. But you have to use that in conjunction with your problem that you're trying to address.
Right.
Yes.
Right? And then we move into the risk area, which is what Dr. Wolf is going to talk about at our conference next month for dermatology. So let's pick on dermatology in the risk section. What are some of the, let's just say they have a chronic condition. I want you to give me a chronic dermatology condition, and I want you to give me a potential addressing of that in maybe the risk column of deciding what to do for that patient.
Yeah. So let's say a patient has psoriasis. Right? There's different degrees of psoriasis, and there can be flare-ups, and it can kind of calm back down. But let's say we have a patient who has psoriasis, and it's now become what's called psoriatic arthritis. So because you have psoriasis, you just think it's a skin condition. Well, the psoriasis doesn't know it's supposed to stop at the skin. It can go anywhere, right? Well, not anywhere, but it can become psoriatic arthritis. So that's arthritis is not typically something that the dermatologist patient doesn't come in when they have arthritis, think I'm going to go see a dermatologist. But if this psoriasis progresses to arthritic psoriasis, that is another level to me. Another example with psoriasis is, what if you may have heard of the term excoriation, where somebody has scratched so much that psoriasis has become so infected. You can self-inoculate and get infection in there. Those types of things, to me, bump up the risk level quite a bit. And
Excellent.
If all the doctor writes is patient has psoriatic arthritis, some people might miss the nuances that will tell me how bad that is, right? It could be simple, it could be more complicated, but elaborate on that arthritis.
Excellent. No, this is beautiful stuff. And there's so many nuances to connecting the dots with different types of specialties, different levels of care. And so I guess if I could get across one thing to our audience is just, if you're a practice manager, for instance, are you allowing your coders to have these conversations with their physicians that they're coding for? Because that relationship needs to be strong in order for your revenue to be correct. And so we want to have those conversations, because they're not going to be able to get in the physician's head unless they have conversations. Now, another thing I always say, and people don't always agree with me, and I want to see if you agree with me, but the physician does not have to word his or her documentation exactly like CPT or exactly like ICD-10 for it to be valid. Your job as a coder is to interpret what they are saying into codes. Sometimes that's easy to do. Sometimes you have to have clarification. But like you said earlier, Dr. Wolf, you have to go, but maybe defend it later. And you can, because what's in the documentation supports it. But again, if we can prevent that from happening by having those conversations, I think it's a good plan.
Absolutely. And I think your point is spot on. It's communication. Like, doctors aren't comfortable talking to coders they don't know, and coders are not comfortable talking to doctors they don't know. So have a donut party one morning. I don't know. Do whatever it takes
that idea.
to get people out of their offices and at least comfortable. Bring those walls down so that people are at least comfortable to just start talking to each other. And this is just even outside of healthcare. If we talk to people, even if you disagree with people politically, you disagree with neighbors, religion, whatever it is, if you just talk to people, they're people. Just let the walls come down. You can solve. You don't have to end up agreeing with people, but you can still be collegial and respectful. And if you could just talk, let's just talk. What's wrong with talking?
Have a conversation. We're human, right? And I think, what are some of the conversations that I want to ask you, Maya, like, as being in the facility yourself and working with a facility, like post-pandemic versus pre-pandemic, did you notice a difference in the way people communicate? There she goes.
I think, it depends on the nature of the conversation, right? And because I think during the pandemic, I think the physicians were overly exceeded in their bandwidth. And I think because of that, the conversations may be short or shorter than normal because they didn't have the bandwidth to think about the dollar, even though the dollar was extremely important. But the vibe of the conversation was very, what do you want now? I've got 10 more patients to see, And so it became really straight to the point. Now that everything is kind of not as serious, it kind of goes back. So, when the AMA introduced that clinical intuitiveness, I think it was really because, the doctor didn't always have time to explain what was happening. And because of that, there had to be some clinical intuitiveness that was between the lines of the levels, right? So, to the point that CJ made earlier, there are some times where you can look at the note and there can be some clinical intuitiveness that's related to the risk that is not necessarily bulletized. It's always in the writing and the nature of how that problem is being written and colored in the note. So
exactly.
Yeah. That's why I think it takes both. Like, physicians need to learn more about the coding rules, but I also believe that coders need to learn more about how physicians think. And so does that mean you have to go to medical school? No.
Yeah.
But the more you know about those conditions, the more intelligent questions you can ask and the better conversations that can occur.
Right.
Right.
Yeah.
And then the more respect that will develop, because the physician's like, whoa, you're asking this really smart question.
Right.
Why does a coder need to know that? Well, let me tell you, doctor, it's the difference between exacerbation and severe exacerbation, or it's
And
the difference between this and this.
And what I found is that when you are intelligent with your questions, right, they are more prone to be more open about it because they know that you've taken the time to understand what's happening and why it makes a difference in that documentation. So that's a really good point.
And
Absolutely.
it's not unique to doctors. Everyone likes to be understood, right?
Yeah.
It's human nature. We like to be heard. And so the more you can give to that relationship that I hear you, I hear what you're saying, the better it'll be.
Yeah.
Absolutely. And I want to thank you, Viola, one of our listeners and our watchers, for asking or just commenting here that introducing yourself to the providers that you're supporting and having the ability to do so is very important, especially if you're new and you're being brought on and they're used to somebody else. That happened to me once. I was taking over that coding responsibility, and it was nice to have the introduction, kind of give them a summary of what my questions might be, maybe a great way to say every so often we'll meet on this day to just discuss any questions you have, and we can kind of have this chit chat about what's going on. And I love it. Don't just show up on their door when something is wrong. That is so disheartening to a physician when they're afraid of you, right? It's like people are afraid of compliance. Like they don't want to be told they're doing something wrong all the time. And so they need to be given that here's what you did good. And here's our opportunity that we have versus this is wrong, because you might be completely wrong as a coder and not even realize it until you have a conversation.
And they're more appreciative when it's an opportunity for them to make more money, or that it creates an opportunity to support what they're doing. Because when it's not supported in the medical record and you're reviewing it, and like, CJ said, understanding that communication and really coming to them with a very transparent thought process so that they can understand what you're saying, and you're saying, there's an exchange, I should say, it makes a difference. Especially when the outcome of it is positive and that both people are walking away with something benefiting from the conversation.
Absolutely. And, I recently, a year or so ago, I was working with a practice, and one of the coders was into the physician's point of view. To them, they felt like they were coming to them and telling them they were wrong. And maybe the coder didn't realize that's how they were coming across, but to the physician, they felt beaten down. They felt like everything they do was wrong. And so I went and had meetings with each of them and just expressed to them, you're not wrong here. But I will say that understanding how this particular payer interprets things, it would be beneficial to have this more clear, but you're not wrong. Right. And I would always tell them, you're doing a great job and you're really giving us a lot here. But in this case, this is perfect. I love this. And then over here, maybe say, there's an opportunity, right, that we can actually capture more here and really tell more of your patient's story. And so there's a lot of ways to use words like that appeal to them, because that's what they really want to do. They want to tell their patient's story, but they don't have time to think through all of this. Sometimes they're being told by admin, you got to see this many patients. We're packing the schedule in today. And so a lot of times they have no control over what they do or don't do in the room.
Exactly.
So Dr. Wolf, if you could give some words of wisdom to our audience, those that are new to coding and maybe those that are seasoned, that to help them keep going. What are some just last minute tips to help them, motivate them to have good relationship with their physicians, to keep going and understanding documentation?
Yeah, this may sound silly, but it'll help a lot if you stroke their egos a little bit. You kind of just mentioned how sometimes you feel like, okay, I'm not doing anything right. all of us kind of like the idea of somebody appreciating what we know.
Right.
So it's not about winning. It's about, being, I'm right, you're wrong. It's about, at the end of the day, people will appreciate when you're there to help them. And if you go into their ego a little bit and say, hey, doctor, you went to a lot of years of school. What did you learn? Tell me about diabetes. What don't I know about it? What, or tell me about, endocarditis. What do I not know about this? That, and if it's the right time and they're not, super swamped, you can start building a relationship that way.
Absolutely. I 100% agree. I thank you for giving your just guidance today, because it's so important for coders and auditors, even practice managers, to understand what you as a physician are going through.
Yeah.
You're a person too,
Right.
and you have a family and you have things that you want to do outside of your job that are important to you. And so you don't want to feel so beaten down by that you don't want to come to work anymore. And a lot of physicians have gotten to that point where they're leaving medicine because they feel so beaten down by the process that could be easier if we just help it along a little bit. So everyone, I want to really encourage you to come join us for the Derm Success East Summit. And it's going to be on March 14th and 15th next month. It is a Thursday and Friday. And I get a lot of questions about this, but employers should see the ROI in attending. And so I encourage you as an employer, send your team on those 2 days. You can sacrifice maybe one or two people. I shouldn't use the word sacrifice, but you should send one or two people in your facility to benefit from this information, because they can learn a lot and bring that back to your organization and really help improve the process. Maybe there is a specific question, a burning question, you can't find the answer anywhere. But maybe you're going to come to the conference and one of our speakers, like Dr. Wolf or Christine Hall or Betty Hovey, they're going to have the answer for you, because they are very seasoned in dermatology and they have seen a lot over the years in that specialty and can help you. So this is your opportunity to ask those questions and get your answers. So I encourage you to attend. We will have the link, of course, is there on the QR code for you. And also it'll be, of course, in our comments later. And we also have tomorrow, I just have to do one last reminder. Tomorrow is the Practice Management Symposium. It is all day, and it's going to cover things like HR. It's going to cover branding and social media with Maya Turner, yours truly. And we're going to have Bertram Lansico, of course, doing HR. We're going to have Jessica Miller talk about AI and technology. Rhonda Buchholz is our keynote speaker, talking about just practice management landscape. Yes. I'll be talking about the patient engagement aspect of your practice, as well as the KPIs and reporting that's so important with your data management. We'll have, of course, the amazing Vanessa Moldovan talking about, from the check-in process to the end, your revenue cycle, what practice managers should know about that, and what they may or may not know about it. And just think about all of the ins and outs that we have in healthcare. And I'm very excited. We have a compliance panel with Terry Fletcher, myself, and Susan Wahlberg, who is a legal professional. She's a lawyer and, of course, compliance professional consultant. Great action-packed day tomorrow. So please join us for that. And thank you, guys. Thank you, Dr. Wolf. Thank you, Maya, for joining in today. It's been a pleasure to speak with you all. And we look forward to our next episode next week with myself and Maya. And Dr. Wolf, I will see you at HealthCon. And Maya, I'll see you in the flesh at HealthCon. Thank you for joining the Healthcare Inspired podcast. Have a great one.
Thanks so much.